Hello, my name is Chris Fry. Today we will be sharing a video tutorial on how to perform ultrasound-guided injections of the elbow and stifle joints in the dog. We have no conflicts of interest to disclose. Ultrasound-guided technique allows visualization of the joint space and confirmation of the needle path and location prior to injection. Pros of using ultrasound guidance were disclosed in the first technical tutorial video of how to inject the shoulder and hip joints. Preparation for approach to these joints is similar to those discussed in the first video in the series. Differences for these joints include the length of the needle and volume of injectate. Most canine elbows and stifles require a 22 gauge needle of 1.5 inches in length for larger breed dogs and 1 inch for smaller breed dogs. The amount of injectate will vary depending on the size of the dog and the joint to be injected, but may be up to a total volume of 2 to 2.5 cc's in the stifles or elbows of larger dogs. For example, the combination of 1.5 cc's of platelet-rich plasma and 1 cc of hyaluronic acid may be injected into a typical Labrador elbow. Triamcinolone acetonide is commonly dosed at 0.2 mg per kg and split across up to 2 target joints and may be paired with hyaluronic acid. For a medial approach to the elbow joint, the contralateral limb should be gently restrained away from the procedural field by an assistant or tether. A small folded towel can be placed under the target limb brachium to add as a fulcrum to assist in antebrachial abduction to widen the medial joint compartment. To locate the appropriate area to place the transducer, palpate the medial epicondyle of the humerus here and the olecranon here. The ulna is the most caudal medial bone and runs lengthwise this way. If you perform a range of motion on the elbow, the medial epicondyle is the center of motion of the joint and will remain still. This will help guide you where the ultrasound probe should be placed, with the heel of the probe on the epicondyle and the distal part of the probe along the length of the ulna. Right away, this sets you up to have the image where you can see the medial epicondyle, enthesis of the flexor tendons, the elbow joint space, and the medial coronoid of the ulna. Once the joint space is visualized as a triangular wedge shape, the ultrasound probe is rocked back slightly to optimize needle approach visualization. The needle is passed bevel up from the distal aspect of the transducer in alignment with the long axis of the probe and under the skin. Once the needle is first visualized by the probe, it may be redirected within the subcutaneous tissues before proceeding to ensure the correct angle to enter the joint space. Once the tip of the needle is visualized within the joint space, synovial fluid may be aspirated for diagnostics or confirmation of placement, and then followed by therapeutic injection. The transducer should remain in place during injection so that distension of the joint capsule may be visualized prior to removal of the needle. With an assistant holding the stifle in flexion and externally rotating the limb, first locate the palpable landmarks of the patella here and the tibial tuberosity here. When the ultrasound probe is placed in long axis between these two anatomic landmarks, the joint space is visualized, and the cranial cruciate ligament can be seen arching from proximal to distal and inserting on the tibia. The patellar tendon is the most superficial structure seen here. With the probe in position, the stifle can be placed through a range of motion to locate pockets of joint fluid. Once a pocket of fluid is located just distal to the patella and femoral condyles, the probe can be fanned medially or laterally, as in this procedure, and the pocket of fluid in the parapatellar region expanded in the field of view. Using ultrasound helps to avoid some of the important structures in the stifle, like the intra-articular ligaments or nearby tendons. The needle is passed bevel up from the distal aspect of the transducer in alignment with the long axis of the probe and under the skin. Once the needle is first visualized by the probe, it may be redirected within the subcutaneous tissues before proceeding to ensure the correct trajectory toward the target. The tip of the needle is seen traveling in the space between the patellar tendon and the femoral condyle until reaching the target joint space just distal and lateral to the patella. The transducer should remain in place during injection so that distension of the joint capsule and recesses may be visualized prior to removal of the needle. Injectate in this dog can also be appreciated as anechoic fluid within the suprapatellar recess. Similar technique may be employed to obtain aspiration or injection of the stifle joint in short axis and lateral to the patella with the limb at a near weight-bearing angle. The probe may be rocked back to improve visualization of the needle passing in long axis to the probe into the valley between the patella and the lateral trochlear ridge into a small fluid pocket. However, the window may be more challenging in small dogs or probes with larger footprints.